It's a genuine privilege and honor to welcome you all to the Bayer Eyesight virtual meeting. Today we are conducting this meeting on AMD. So today's our speaker is Dr. Vedant Shah. Sir is a renowned retina specialist and Sir is associated with C Netro Eye Foundation. And today's another speaker is Dr. Arnob Das. Sir is a senior ear surgeon of Disha Eye Hospital. And today's our first topic is NAMD, clinical information for clinician to enhance patient outcomes. And the speaker is Dr. Vedant Shah. So I'm requesting Dr. Shah to kindly start your presentation. Thank you.
Oh, thank you so much, Abhishek. Am I audible?
Yes, sir, you are audible.
Okay, I'm just trying to share my screen. Just let me know once it is visible.
Sure, sir. Yeah, it's coming, sir. It's coming.
Wonderful. So, thank you for the opportunity. I'll just go on slideshow and we can start. Great. Okay, so we all know that neovascular AMD is the rising prevalence of neovascular AMD is causing so much havoc, and it is estimated that around 288 million people will be affected by this condition, and this substantial global burden indicates that we need to know more about neovascular AMD. I have no financial interest, and these slides have been provided by Bayer. So I'm just going to elaborate on certain things that I feel as a clinician it is important for us to know. The main symptoms that we are looking at is the blurring of central vision, visual distortion, that is suddenly the straight lines appear to be bent. There is a central scotoma that happens, and also a general haziness in the overall vision. So when it starts from dry to when it becomes a wet AMD from dry, the symptoms appear suddenly, and there is a worsen that happens rapidly over a very short period of time. So the initial visual symptoms appear like this, and as the worsen happens, the central scotoma tends to appear, and it starts to affect the quality of vision and the quality of life in such patients. So there are stages of AMD, as I mentioned. There is an early stage or a dry stage where the drusen starts to collect under the retina, and then gradually, as these changes happen in intermediate stage and in the early stage and the intermediate stage, the central vision starts to be affected, and we can see the early changes in the retina, in the OCT, and also in the fundus autofluorescence. As it progresses toward a visually threatening condition, it can either result in an atrophic geographical atrophy, or it can result in a wet kind of a AMD, which leads to sudden loss of vision. So to identify this, there are a lot of tests that the patient needs to undergo. Most importantly, examination using 78 or 98D followed by an indirect ophthalmoscopy, fundus fluorescent angiography, OCT, and also OCT angiography. And in some patients where the diagnosis is still impervious and we are unable to find out whether it is because of the polyp or because it is of some other reason, it is also important to do an ICG, because it is still FFA and ICG still form a baseline gold standard tests in places where OCT angiography doesn't work. So the main aim of doing this AMD management is basically to reduce the treatment burden while also maintaining the vision. And thereby, it is very important to diagnose this treatment as early as possible, because the time lost is equivalent to vision lost. And it is equally important for us to communicate very clearly with the patients and also with the patient family, so that the permanent chances of permanent vision loss doesn't happen. So what are the key factors that drive the mechanism, or what are the key factors behind the pathogenesis of vascular AMD? If we are to understand clearly, we can see that it is basically because of the VEGF-A and VEGF-A and the placental growth factor, which lead to sudden increased vascular leakage and edema. and thereby causing pathological neovascularization. They work in tandem, and therefore PIGF acts both directly via the receptor 1 and receptor 2 by displacing the VEGF-A from the VEGR receptor 1. How aflibercept works in comparison to other anti-VEGFs is basically that it looks into the action of VEGF-A, B, as well as it tries to control the placental growth factor, thereby inhibiting the direct contribution. And if they are able to bind to the receptors, the VEGF-A is completely blocked, and thereby VEGF-B and PIGF would still be able to bind to the receptors and contribute to the downstream pathological side effects. So these are the currently available anti-VEGFs in the market, and we know that each one has gone through a number of trials. There are a lot of online trials that are available for us to go through. Everyone has their own indications. Some are indicated specifically for AMD and PCVs. Some are indicated for diabetic retinopathy, vein occlusions. So if we are to look into aflibercept, overall, it targets it has a multiple target, and that is why aflibercept seems to work better in comparison to the others that are available. In aflibercept, if we are to use in wet AMD, there are RCTs that are available, and the most common one that is there, which highlights the use of aflibercept, is the ALTAIR, which was a multicentric randomized open label phase 4 study in patients with naive AMD. Approximately 247 patients were enrolled here, and it was found that the mean change in BCVA and the injections that were used even after the 52 weeks, and when they were continued to be monitored at 96 weeks, it was realized that the number of injections that were required for the patients had drastically reduced, as well as the mean visual acuity that had improved. They were able to maintain it with the use of aflibercept. Also, if you were able to see that, as I was mentioning, it has been highlighted in the graph here, that the mean change in the BCVA from baseline was seen at the primary endpoint, which was at 52 weeks. And more or less, they were able to maintain the BCVA. However, the number of injections had drastically reduced in such patients. The primary endpoint, when the extension was continued and mean BCVA change was noted in view 1 study, the baseline at week 212, it was noted that some amount of visual acuity maintained over the 5 years, though some patients dropped out, though some patients had repeated injections, multiple injections required. However, the overall dosing was studied, and it was found that the visual gain was approximately maintained with proactive dosing as per the study protocol. So these are various other studies which highlight the use of aflibercept, and it also highlights how the visual acuity continues to be maintained in such patients, and the number of dosage or the number of injections that are required overall seem to be much lesser as compared to any other anti-VEGF. This similarly, another study from the UK, and Jaggi et al. In 2020 also showed the same, that by year 4, the median injections were and the injection interval were much lesser, maybe over just about 2.5 to 3 months. And the mean number of injections that were required also drastically reduced as the patient continued to take aflibercept injections. So this is just a comparative study that helps us to understand how view 1, ALTAIR, and the other studies that are lined up corroborate to what I'm saying as how the number of injections per year reduce. Importantly, if we are to look at the randomized control trials, we should always make sure that some patients require treat and extend, some patients require multiple checkups. Some patients also need to undergo few tests. So it is important to tailor, as per the patients, to tailor the treatment, whatever they require, in accordance to the tests that I mentioned previously. Now, if we are to look at aflibercept as a choice of anti-VEGF in PCV, it is equally good, equally efficient, and equally important to understand that aflibercept works really well in patients with PCV. And this PCV is mostly seen in the Asian population, almost 22.3 to 60% of the patients in Asian population, and that is why have PCV. We diagnose a patient with AMD, but sometimes when the patient doesn't get better even after multiple injection and the patient undergoes ICG, it is found that there are polyps that are there which need to be treated, and that is why PCV may be an underdiagnosed condition in a large number of population. And the most important study that comes to our mind while we are treating patients with PCV is the PLANET study, where aflibercept monotherapy was compared with aflibercept and active PDT. And in some patients where aflibercept monotherapy failed to give desirable results, a rescue therapy was also done in such patients. And it was found that the mean BCVA or at the primary endpoint at 52 weeks were almost similar to aflibercept monotherapy alone as compared to the aflibercept with PDT. And this continued even at a longer stage at 96 weeks. And it was found that the aflibercept therapy with sham PDT performed almost equivalent or a little better as compared to the aflibercept with active rescue PDT. So if you are to look at the evidence of active polyps at 52 and 96 weeks, it was found that the proportion of patients with active polyps were much lesser in patients with aflibercept monotherapy, as well as it was noted, or rather very similar to the ones with who received aflibercept with active rescue PDT as well. So across various studies that were there, it was also seen that the studies were in the Caucasian population, the Southeastern Asian population, and the Japanese group, including the RCTs like Apollo and Planet, showed that patients with aflibercept had a clinically meaningful visual gain. And overall, the usage of aflibercept monotherapy was clinically highlighted. The aflibercept monotherapy has been also highlighted in a large number of other studies as shown here. So, to my understanding and to my knowledge, aflibercept for me is the primary choice of therapy in the initial stages. I usually go by the loading dose therapy and then treat and extend if required. However, if even after the third dosage, if the patient doesn't show improvement or the progression of the disease continues, then I also look into ICG and try to understand if there is something that I'm missing. Overall, aflibercept is the mainstay of treatment not only for ANMD, but it has also been indicated for other diseases like BRVO, CRVO, DME, also in other state and countries for NVG and ROP. More than 20,000 patients from 20 countries with real-world studies highlight the use of aflibercept and gives us a lot of a positive impact as to the use of aflibercept. And the most important thing to note is that the inflammatory component with or the IOI with aflibercept is much low as compared to the newer molecules that are available in the market now. Thank you so much for the patient hearing. I'll be happy to answer if there are any questions.
Thank you, sir. Thank you for a very insightful presentation. So, sir already said that now the forum is open for the audience. If anyone has any question, they can raise their hand or directly ask the questions. Otherwise, I think we can.
I just
Yeah, yeah.
wanted to, I mean, it was a
Yes.
wonderful presentation by Vedant, smooth, free-flowing presentation as usual. Uh, uh, and that's what I like about Vedant's presentation. He keeps it simple. All I wanted to tell the house is that it is only when aflibercept arrived that we could think of a monotherapy in PCV. Prior to that, we only had ranibizumab, and ranibizumab was not enough as monotherapy for PCV. PDT was required. And even if you see the comparison between not a direct comparison, but basically trial to trial comparison, where you compare Everest with Planet, you would see that aflibercept monotherapy scores over even ranibizumab with PDT. So basically, yeah. So aflibercept is more powerful in PCV alone than even PDT plus ranibizumab combination. So that is one thing that I would want the house to keep in mind, that when you're treating serious diseases, think of newer molecules. And as Vedant has mentioned in his presentation, and the last slide spoke volumes about the safety of aflibercept. I mean, yes, even bortezomib is a good molecule for NMD and PCV, but there are concerns about IOI, and especially when you are thinking of using that molecule for repeated doses, especially as treat and extend. Aflibercept doesn't give you that kind of a concern, right, Vedant? So you can
Yeah,
give hoping a good result and sleep at peace.
absolutely. I think we don't have to think twice before we ask the patient to undergo aflibercept in comparison to the other molecules. The choice of patient and the selection criterias are quite elaborate in such patients. However, with brolucizumab and other newer molecules, we need to be a little concerned and safety. We have to think about the safety first.
Mm. And also in this Planet study, they had two very important arms. Aflibercept is a powerful tool, more powerful than ranibizumab plus PDT. But the Planet study showed us that the addition of PDT was not of much use. Even in those who needed a rescue therapy, I mean, there were two options, as Vedank you were mentioning. One is where they actually received rescue PDT, and the other where the aflibercept doses frequency was cut down and was increased. So basically, just a more aggressive monotherapy with aflibercept uh, alone worked equal or maybe at times better than aflibercept with PDT also. So basically, PDT, we are handicapped in the fact that it's not available, but that's hardly a handicap given the kind of wonderful molecules that we now have at our disposal. Right, Vedant?
Yes, absolutely, sir. Right on target.
Yeah. Okay. Now, Abhishek, should I present?
Yes, sir. Yes, sir. Thank you, sir. Thank you for your
So,
valuable.
yeah. So Vedant has made my job easy. Actually, he has spoken of the results. I will speak why we get those results. So, so now, are my slides visible,
Yes, sir.
Abhishek?
Visible. Yes, sir. Yes, sir. Visible and it's come and the slideshow view. Is
Okay.
everything
Okay.
is
Okay. Just a second. So I'll be talking on evaluating anti-VEGF drug molecular characteristics and their impact on treatment success. Uh, it's not moving. I need to share again. I'm sorry about that. It's not moving. I'm sharing again. Huh?
okay, sir.
Mm. Yeah, now it's moving. So as I was speaking, I'm to speak on evaluating anti-VEGF drug molecular characteristics and their impact on treatment success. So most of the slides have been provided with by Bayer, but I have put in my own inputs. Anti-VEGFs can be divided into conventional ranibizumab and bevacizumab. and newer and anti-VEGFs which are aflibercept, bevacizumab, and faricimab. Several molecular factors determine how a drug interacts with the body. So they are the binding affinity, the elimination half-life, potency, clinical targets, and molar dose. Thus, these are also the 5 pharmacological strategies to try and achieve greater biological activity and extend disease remission uh, by increasing the binding affinity, increasing the potency, increasing the half-life, having more pathways and clinical targets covered, and increasing the molar dose. Attempts to improve binding affinity. The dissociation constant, or KD, is a measure of the affinity between two molecules, a ligand and a receptor. And since it is inversely related to binding affinity, lower the KD value, tighter is the binding. One can note from the table that aflibercept scores well here and has a VEGF-A binding affinity almost 100 times that of ranibizumab and much higher than other anti-VEGFs too. Binding affinity determines how strongly a drug interacts with its targets. Aflibercept was found to have statistically higher VEGF binding affinity than bevacizumab and ranibizumab in a head-to-head study. Higher affinity can potentially lower the minimal efficacious concentration required to block a given factor. The second thing which companies target is attempts to improve potency. IC50 value is the half maximal inhibitory concentration is correlated with drug potency. It is a measure of the concentration of drug required to inhibit a particular biological or biochemical process by 50%. Lower the value, more potent the drug. Aflibercept is significantly more potent than bevacizumab and ranibizumab in vitro. Talking about attempts to increase the half-life. Half-life is largely a function of the drug size, and half-life changes the slope of the curve, as you can see on the left. Graph shows that a greater half-life allows a longer duration of biological activity in the vitreous of the eye. This increasing half-life results in increased intervals between necessary treatments, decreasing the treatment burden with any given agent. If you see the estimated intraocular half-life in days, one can note that bevacizumab, being a smaller molecule, loses out on half-life vis-a-vis larger molecules like aflibercept, though bevacizumab attempts to compensate this by a very high molar dose, having more pathways and clinical targets covered. Depending on what these molecules block, we know that there are single target drugs like bevacizumab, ranibizumab, and bevacizumab, all of which target only VEGF-A. You have dual target drugs like faricimab, which targets VEGF-A and angiopoietin-2, and you have multi-target drugs like aflibercept, which not only blocks VEGF-A but placental growth factor, also VEGF-B and galectin-1. The VEGF signaling pathway is the master regulator of pathological angiogenesis. For recollection, VEGF-A acts mainly through VEGF receptor 2, but also through VEGF receptor 1, whereas VEGF-B and placental growth factor acts only through VEGF receptor 1. Angiogenic factors play a critical role in the development of edema, retinal vascular permeability, inflammation, neovascularization, and vessel stabilization. Activation of VEGF receptor 1 and VEGF receptor 2 by VEGF and placental growth factor promotes angiogenesis and neovascularization. As mentioned, aflibercept targets VEGF, the master regulator of disease pathology, and additionally targets the key ligand placental growth factor. And the FC portion of IgG extends the half-life of aflibercept. VEGF-A and placental growth factor are upregulated in exudative retinal diseases such as diabetic retinopathy, DME, and neovascular AMD. In patients with DME, VEGF levels are up by around 61 times, and the placental growth factor levels are up by around 19 times. Why placental growth factor is an important target molecule? Although other anti-VEGFs block VEGF molecules from activating VEGF receptors, presence of elevated placental growth factor can also activate VEGF receptor 1 receptor and therefore promote angiogenesis, leakage, etc. Could targeting additional pathways beyond the VEGF receptor pathway further improve efficacy outcomes? Aflibercept inhibits multiple targets, as we have learned. In the previous trials, platelet-derived growth factor receptor inhibitors have demonstrated no additional functional benefit vis-a-vis anti-VEGFs alone. But what about inhibition of angiopoietin 2, which is much in news and much in noise? It is important to remember that the levels and ratios of angiopoietin 1, angiopoietin 2, and VEGF-A are important. Angiopoietin 1 and Tie2 binding promotes endothelial survival and stability of cell junctions, thus stabilizing vasculature. Whereas angiopoietin 2 inhibits Tie2 activation by competing with angiopoietin 1. It is, however, expressed at lower levels than angiopoietin 1 in healthy tissues. And we know VEGF-A binds only to VEGF receptor 2. Faricimab is a bispecific monoclonal antibody that directly binds and neutralizes both VEGF-A and angiopoietin 2, effectively blocking their signaling pathway. Whereas aflibercept is a recombinant fusion protein, a decoy receptor that binds VEGF-A, VEGF-B, and placental growth factor with greater affinity than body's native receptors. Aflibercept is therefore a decoy receptor that simply traps the signaling molecules which mistakenly bind with aflibercept instead of the original receptors without initiating a cellular response, therefore reducing activity. Is Tie2 pathway always relevant target for treatment of exudative retinal disease? In high VEGF states, angiopoietin 2 antagonistic activity may promote destabilization of blood vessels. We understand this. However, in low VEGF states induced by anti-VEGF treatment, angiopoietin 2 may have limited relevance. You'll understand this more if you see this. In faricimab phase 2 trial, which is Avenue, ranibizumab and faricimab achieved similar levels of plasma angiopoietin 2 inhibition after one injection. Thus, data suggests that anti-VEGF monotherapy neutralizes angiopoietin 2 to levels comparable to that of directly targeting angiopoietin 2, supporting the belief that biological activity of angiopoietin 2 is downregulated by decreasing VEGF levels. This animal study evaluating the efficacy of anti-VEGF agents ranibizumab, aflibercept, and bortezomib in human VEGF 165-induced rabbit retinal vascular hyperpermeability model found that human VEGF was completely suppressed in rabbit vitreous after anti-VEGF treatment for 28 days, and angiopoietin 2 protein in vitreous and MRA for the angiopoietin 2 gene in the retinal tissue was similarly suppressed, although anti-VEGF agents do not directly bind to angiopoietin 2. Aflibercept demonstrated the greatest inhibitory effect in Ang2 levels in vitreous, which correlated with strong durable suppression of intraocular human VEGF as well. The results of this study support the hypothesis that angiopoietin 2 may be expressed secondarily through primary insults to the retinal vasculature by VEGF. So if that is blocked, then angiopoietin 2 levels will come down. Bayer and Regeneron have investigated the angiopoietin 2 pathway in combination with aflibercept in the Ruby and Onyx studies. Data from separate studies suggest that nesvizumab is a more potent inhibitor of angiopoietin 2 than faricimab. Even then, no additional clinical benefits were noted with this potent angiopoietin 2 inhibition in combination with aflibercept. The Ruby for DME and Onyx trial for NAMD program was thus discontinued primarily because combination therapy was non-inferior to aflibercept monotherapy for change in BCVA at week 12 and week 36 endpoints in both the trials. Faricimab also examined angiopoietin 2 inhibition in combination with VEGF, but did not offer any visual improvements over aflibercept 2 milligrams in phase 3 trials. Unbalanced study designs favoring faricimab and the additional angiopoietin 2 targeting with faricimab did not confer any additional clinical benefits over aflibercept, as you can see through these line diagrams of Yosemite and Ryan and Tenai and Lucer. It seems the activity of faricimab may be derived primarily from its ranibizumab arm. No proven clinical benefit with angiopoietin 2 inhibition. It could be that the higher molar dose of ranibizumab uh, uh, arm in faricimab is responsible for the kind of effect we see with faricimab. And maybe angiopoietin 2 doesn't really blocking of angiopoietin 2 in with faricimab uh, is not of that great importance. It's only because that ranibizumab is in higher concentration in faricimab. That is why probably we get better results with faricimab than ranibizumab. Now, attempts to improve molar dose. Molar dose is the amount of drug delivered at a single time, and increasing it moves the curve up, as you can see. That is biological activity increases and stays for a longer time. Note the shift to a more prolonged action with higher molar dose. Increasing molar dose has been a common strategy to increase biological activity since the results of the pivotal Harvard trial, which looked into ranibizumab of 0.5 milligram versus ranibizumab of 2 milligram. In the PRN arm of the study, the average interval between doses after loading phase of 3 monthly injections was longer in patients who received 2 milligram. This suggests that administering a high dose of intravitreal ranibizumab could result in longer biological activity of the agent. Similarly, increasing the dose of aflibercept to 8 milligrams from 2 milligram, as seen by the two studies, Pulsar in NAMD and Photon for DME, allows extending dosing up to 16 weeks immediately after the initial 3 loading doses. In regards to vision gains, 8 milligram aflibercept, when given with an extended dosing interval of 12 to 16 weeks, was non-inferior to 2 milligram aflibercept given 8 weekly. So molar dose does have an effect. Thus, increasing the dose of aflibercept per injection alone has the potential to reduce treatment burden without compromising vision. Uh, it's in most of the aspects of molecular properties, it seems that aflibercept is superior to other available anti-VEGFs, as you would have realized by now. And as Vedant was also mentioning, it can be seen from some real world studies, RCT-like outcomes are possible with aflibercept even in clinical practice, be it in NAMD, PCD, or DME. And this also Vedant spoke of that aflibercept has become the benchmark for efficacy and safety with years of real world patient experience. I'll not read through this summary. I've spoken enough. You know what all of the this is. And so thank you for your patient listening.
Thank you, sir. Thank you for a great presentation. So the forum is open for the audience and for also Dr. Shah. If you have any questions, you can ask.
I have question. Rather, I want to ask Arnab sir.
Yes, yes, sir. Yes.
Sir, what about the 8 milligram?
No, I'm waiting for it. But I mean, as you know, in US and all, I mean, 8 milligram. Abhishek will probably second that. I mean, 2 milligram is hardly being used these days. It's primarily 8 milligram in US. Maybe somewhat similar trend is also there in Europe, but unfortunately, we are waiting and waiting. I mean, see, I mean, if you can keep a gapping of 16 weeks, it's 4 months. So 4 months means 3 injections in a year. Patients psychologically and financially are pretty comfortable with that. And I'm hopeful that when we have an 8 milligram, I'm sure it will be pricier than a 2 milligram, but they will have a patient support program. And Abhishek probably knows much more than me. But I heard Chetan, their national head, saying that yes, they are considering patient support program to be there for the 8 milligram, although they have removed it for the 2 milligram. So we are looking forward to 8
Yes,
milligram, and I'm
I think
sure it's going to be it's going to
I think
make
it'll
some
change.
difference.
It'll revolutionize the way treatment is done now.
Yeah, yeah.
Abhishek, you want to share some information regarding the 8 milligram?
Yes, sir. We are expecting at the start of the last quarter, like September or August, we are going to launch 8 milligram in India with patient support program, sir. That's the
And
latest
Vedant,
update we are.
right. And Vedant, I mean, yourself, they're pretty generous with the amount they give in a while. It's generally more than 0.1. I sometimes give it nearly 0.1. Even I know people like Zahir also does it. So although I mean, 0.05 is sufficient, ml I'm talking of,
Yes.
but I give 0.1. So basically, I am kind of using 4 milligram. I mean, it's not higher molar dosing, but I mean, because of the volume being more, I mean, there are more molecules going in. But if you have to do that, you have to give a Diamox or something, or you have to do a paracentesis. Otherwise, there's going to be a little bit of discomfort for the patient.
Correct.
So
But
keep
there is
that in mind.
no scientific evidence. You are just doing it from
No,
your
no, just
experience.
no, not scientific. I mean, see, no, scientific evidence is coming from the 8 milligram. Na. So I mean, especially suppose you're getting a little bit of a suboptimal response with aflibercept. Then the next time you give, instead of 0.05, since thankfully they give us a little bit more, you can
Yeah,
give
I
what you
think
feel like, a little
that
bit
is
more.
something worth a trial.
Yeah, yeah. Now, I know of people who do it. I can vouch that even Zahir does it, and he has been pretty vocal about it.
Great.
But this and 8 milligram are two different things. In that, the
Yes.
volume will be appropriate. Okay. So, I
Correct.
mean, in
Those
patients
are
with
the molar
compromised disc,
dosage and the volume will be appropriate, you mean?
yeah, in patients with compromised discs, I can't give
Correct.
0.1.
Correct.
So there are limitations.
Right.
And sir, right, sir, you rightly said. And one thing is, sir, that we are not increasing the only like from 2 mg to 8 mg. What we have received the information that the molecular structure will be different from 2 mg to 8 mg. Like the structure will be different.
No, sir, certainly. Just adding something with the Abhishek is not the it's not the structure, but the, as you said, sir, Arnab sir. So the
Mm,
volume will be the same, like a
mm,
0.05 ml will inject, and the
mm.
packing will be high. So molar concentration will be high in the volume, means the solutions. So ocular clearance will be slow in that case. So the retention will be high. Yeah.
So, I mean, parallelly, then pushing it might be little more tighter than what we are
Yes,
used to.
tighter. That will be more
Little
viscous
tight.
rather than yeah,
Yeah,
current solution. Yeah.
correct.
Yes.
We have got used to pushing more viscous fluids now. If I remember, is pretty viscous.
Yes, yes.
Yes.
So yeah, so we have already been primed. But please get it as fast as you can. I know there are where things are stuck, but we are looking forward to it.
Absolutely, sir. We are also to
The Bayer
we
is, yeah, Bayer is also working with this as quick as we could be able to launch this brand in India.
Yeah, yeah.
So if there is no question from audience side, then I think we can close this event. But thank you, Dr. Vedant sir and Dr. Arnab sir, for your very insightful presentation. It will really help our audience for their day-to-day practice. Once again, thanks from Bayers.
Yeah, yeah, yeah. It's
Thank
always
you
a
so much.
pleasure. It's always a pleasure being on your platform. Chalo, Vedant, nice seeing you. Good night.
Same here, sir. Good night.
thank
Good
you,
night.
Thank
sir.
you, sir.
Good night, both
Good
of you.